Good afternoon, dear colleagues and seniors and students, if any, being a Sunday. And I would like to extend my thank you to Dr. Vitull. Thanks, sir, for giving me this opportunity to present this topic in front of the apt audience. So beginning with this, I would like to welcome you to the scintillating world of nuclear medicine, where we say the unclear becomes the clear. Myself, Dr. Yasmeen Atwal, nuclear medicine consultant at Bathinda Scans, that's a unit of KP imaging. And my topic for today is non-oncological applications of nuclear medicine. Why specifically non-oncological? Because basically nuclear medicine came to be known widely and vastly because of the PET. But there's a lot that goes beyond the PET that formed the basis of the initial nuclear medicine and the procedures that are still being done to date. So, we at Nuclear Molecular Imaging Center at Bathinda Scans, we do both oncological as well as non-oncological imaging. For that, we have the two scanners. We have the PET-CT scanner, which is GE Discovery, on which we do the mainly oncological scans like cancer staging, treatment response, recurrence, and the follow-up. And another, we have the gamma camera that forms the basis of the non-oncological imaging. It is the Infinia Hawkeye. So our center, it has both the machines, and as such, it is the only full-fledged nuclear medicine center with both the scanners in the region, next to it being the DMC Ludhiana. So the uniqueness of nuclear medicine studies lies in their ability to demonstrate function, physiology, and metabolism. So a diagnostic nuclear medicine study is useful in the determination of the cause, manifestations of a disease, monitoring the progression or regression of a disease in response to therapy. The procedures very often identify the abnormalities in the very early in the progression of a disease before the anatomical imaging detects it, because it is based on the function. Ability to quantify inherent property of all nuclear medicine procedure. We will see how we quantify in the non-oncological imaging aspect. So the basic components of any nuclear medicine procedure is radiopharmaceutical acquisition system. That means our scanners. We have the PET scanners and the gamma scanners, and then the analyzing system through which we interpret the scan and correlate it with the clinical presentation and previously done radiological findings. History taking clinical aspect is very important in nuclear medicine scan correlation, as it is, again, I will stress, functional and physiological imaging. So how do we image? First of all, we need a radiopharmaceutical. Radiopharmaceutical basically has two components, a radionuclide and a pharmaceutical. Radionuclide is the activity which we inject in tracer amount. It can be titanium, technetium, iodine-131. These are for the gamma cameras, and F18 as for the PET scanners. When this is tagged with the pharmaceutical, pharmaceutical is organ specific or cellular uptake specific. Like suppose most commonly being done is F18 FDG. The FDG, fluorodeoxyglucose, it mimics the normal glucose uptake mechanism via GLUT receptors into the cancer cells. When we tag it with the radionuclide, that is F18, we are able to see it, image it. So the radionuclide gives us the images. Basically it is what produces the scintillation. So it makes the radiopharmaceutical complete the two components. So initially this is the first cyclotron that was made in the 1830s, long ago. Now we have the most compact modern cyclotrons called medical cyclotrons. These cyclotrons are the production units for the PET scanners, that is FDG. Basically three resources of the radionuclide production we have. We have the cyclotrons, we have the generators, and of course we have the nuclear reactors. Most commonly nuclear reactor produced, we get the iodines for the treatment of thyroid cancers plus many other things. Then we have the cyclotrons, which mainly give us for the PET scanners. And the third thing that we have is the generator. This is what is used in the non-oncological imaging. This gives us a roughly 15-day supply of the radioisotope, which when tagged with the pharmaceutical, we can image different organs. It might be renal imaging specific, It might be skeletal imaging specific or thyroid specific, depending upon the uptake of the pharmaceutical the radionuclide is tagged with. These are the pharmaceuticals, also known as the cold kit. This is what we tag with the radioactivity. So what is basically nuclear medicine imaging? It is basically an emission scan imaging. Radiology is a transmission scan imaging, that is, from a source the radiation is passed through and through patient's body and an image is created, like an X-ray or a CT. Whereas in nuclear medicine, the radio tracer or the radiopharmaceutical is injected into a vein. It emits gamma radiation. As it decays, gamma emission produces scintillation, which results in the formation of images. Now suppose we have injected this patient with MDP, 99M technetium MDP. 99M technetium is the radionuclide, MDP is the pharmaceutical. MDP will get chemi-absorbed onto the hydroxyapatite crystal of the bone matrix, and it will be taken up by the bones. Any abnormal activity will be highlighted, whereas physiological uptake is also going to be there. So this is how the bone scan is going to look like. It is so specific that we don't see anything else in the body. At the most, we see the kidneys because that forms the basic route of excretion. So what do we image if not oncological in nuclear medicine? We have a lot to do. We do the endocrine, thyroid, parathyroid imaging. We have the renal imaging. We have the gastrointestinal imaging. We have hepatobiliary, skeletal, cardiac, and so on, including lymphoscintigraphy. What in endocrinology do we do? We have the thyroid scans and the parathyroid scans. The most commonly used is the first one, technetium pertechnetate. Whereas in parathyroid scan, we utilize other techniques also, subtraction techniques, but all these are done only on gamma camera itself. So thyroid scintigraphy. Suppose we get a patient with high levels of T3, T4 and suppressed levels of TSH. So what is the cause? There might be many. It might be an autonomous functioning thyroid nodule. It might be Graves. It might be multinodular toxic. Then it might be thyroiditis. What is causing it? We'll sort the treatment, we'll give the treatment. So the first thing we do is we image it after we get these lab values referred by the consultant. So we detect thyroid nodule, thyroiditis versus hypothyroidism, and few hypothyroid conditions like congenital hypothyroidism, agenesis of thyroid, or lingual thyroid, that is ectopic thyroid when it is not located in the normal location. Then we have a thyroid cancer follow-up in which we use iodine 131 as well as for treatment and also for the scanning. So here we see the thyroid uptake. It is anterior imaging. We do anterior and posterior imaging depending upon the organs that we are trying to image. So this is anterior imaging. We see the left lobe is completely suppressed in the first image, whereas we see a very hot or increased uptake in the right lobe. This was a case of autonomous functioning thyroid nodule that went totally out of control of the feedback mechanism, was functioning on its own, and it suppressed the left lobe. Next is the Graves' disease. Both the lobes are appearing so hot. The uptake is very high. It is 48.6. Normal value is 0.424%. So the person was grossly toxic. And since we had to put him off medication like neomercazole or methimazole, we had to replace it with the Ciplar to counteract the side effects of this hyperthyroidism. So here I'll show the image of toxic MNG. We see the nodules. We see one very hot big nodule plus other small warm nodules. Also we have a cold nodule in the left lobe in between the two warm nodules. Now Hashimoto's thyroiditis. In this we see so much of background and so much of less uptake in the thyroid lobes. So this is how we differentiate these different conditions. Then this is the lingual thyroid. We see in the center, we put markers, chin marker, SSN markers, and in between the salivary glands, we see the uptake. That was the lingual. And then next is the agenesis of thyroid. This is when thyroid detects malignancy. It will be cold on the technetium scan, but if we give it MEB, that will be taken up by the nodule. If you can vaguely see, there's a nodule that is not seen in the first image, but when the same patient was scanned after injecting MEB, it was hot. So this hinted at the malignancy rather than a benign condition. And this is the therapy scan, post-therapy scan. In this we see uptake in the lungs. This is I-131 iodine scan. So what do we do in parathyroid scintigraphy? Detection and location of parathyroid adenoma. It has high sensitivity and specificity. We have two techniques, single tracer technique and dual tracer techniques. I'm going to share with you a very rare case, we did here only, of bilateral parathyroid adenomas. Since we had a doubt, we see the two dots in the neck. Just where thyroid is located. We did the subtraction study also to reconfirm it, since that has a higher sensitivity and specificity for the same. And here in the third image with arrows pointed out, the thyroid is white in color and the parathyroid adenomas are clearly visible thereafter. So next, what is the role in nephrology? To see the differential function of two kidneys. The function is given in ERPF, effective renal plasma flow, or the GFR, depending upon the agent used. Also, it is given in a percentage cortical split function out of 100. So the things we use for it is a 99 technetium DTPA, which is a glomerular agent. It gives us the GFR. And 99 technetium EC, it is a tubular agent, it will give us ERPF. Now where to use this DTPA or EC? Normally written is DTPA. At times we have to change it to EC. EC is basically done in pediatric population and in patients with creatinine higher than 2. Whereas DTPA is routinely done in normal creatinine values in a population more than 16 years of age. And then this is the dynamic imaging. We see the flow, we see everything, we generate graphs. Whereas in the renal cortical imaging, this is a static imaging basically for the cortical split function given in percentage and the scarring. So this is a graph, this is an EC scan. This child was 10 years old. He came to us with a history of renal calculi, pain on right side of abdomen. It's a posterior imaging since kidneys are located posteriorly. So as we see, the right kidney is seen pulling up in the subsequent images. The left kidney graph is seen coming down, whereas the right kidney graph is seen rising up. So this hinted at the obstruction in the right kidney. Next scan is of ectopic kidney. They wanted to know the function of ectopic kidney and its flow status, whether any obstruction is there or not. This is a posterior imaging. We see the left kidney, just a second. This is an interior imaging. We did this interior imaging. The ectopic kidney is located just above the bladder on the pelvic brim. And we see the obstructive pattern of it. Left is the, since it is interior imaging, left is showing obstructive pattern, the graph is going up. But since it is ectopic and it is more anteriorly located, in this we do anterior imaging also. This is for the same patient. Now, where is this renal imaging needed, especially the DTPA and the EC? It is needed in the kidney trauma, kidney transplant, urinary tract obstructions, renal artery stenosis. For this, we have the captopril renogram, hydronephrotic patients, kidney abscess, and polycystic kidney diseases. Another aspect in this is DMSS scan that mainly detects the scarring. Reasons might be many, like acute pyelonephritis. It detects ectopic tissue. It detects renal abnormalities and the non-functional status of the kidneys. So this is a normal DMSS scan. We draw the arrows around the two kidneys and we get the percentage. So the left one is working 43.5% and the right is working 56.5%. We have a cutoff for the salvageability, below which if the percentage comes, we say the kidney is not salvageable. This is the image of acute pyelonephritis. On left kidney in the upper pole, we see a photopenic area, which after 3 months of post-antimicrobial therapy, it healed with no scarring. And this is the corner image which shows of another patient which shows scar in the left kidney upper pole region. It is a wedge-shaped defect which is known as the scar. Now this is a horseshoe kidney that we found on DMSA. We see the upper poles of both linked to each other. Now the left renal agenesis, left cortical tissue, no uptake, no functioning renal cortical tissue. This is cross-ectopia. Now, what is nuclear medicine in gastroenterology? We do GI bleed scans, we do ectopic gastrical mucosa or Meckel scan, gastroesophageal reflux studies, gastric emptying, and also colon transit studies. This is not a very good image of RBC scan. So we see the bleeding and we can quantify the arteries, point the arteries, which is the region like superior mesenteric artery or inferior mesenteric artery from which the bleed is coming. And this is a Meckel scan. The bigger increased uptake that you see, that is the stomach. And the rule for the Meckels is as soon as the stomach is seen, the abnormal focus should also be seen, the ectopic gastric mucosa, because the mechanism of uptake is the same. So we see a small dot on the left side in the abdomen, that is the Meckels. Now GE reflux study, especially done in pediatric patients, non-invasive procedures. And in 24th frame, we see the reflux, a spike going up till the mouth. This is the grade 3 reflux that we see. Now we do the gastric emptying studies, we quantify it. And here we have done this study at our center. And at 1 hour, we see the emptying time, it is 56%. The normal range is 30 to 90%. For different type of meals, it is different. And this is another scan. At 57 minutes, the frame time. 57 minutes, the emptying is 52%. The graph is created and it is very well quantified. This is the colon transit study that we have done. And this turned out to be a case of a redundant colon. The transverse colon, we see the activity is retained even at 48 hours. This is another scan. This is a normal scan. Colon transit study. In the last image, we see nothing is retained in the abdomen. We also do the salivary gland scintigraphy. In cases like dry mouth, Sjogren's syndromes, parotid tumor, post-radiation therapy, especially in the head and neck cancers. So the first 2 rows are the normal uptake of the mandibular and the parotid glands, whereas the last 2 rows are after Lyme stimulus when the activity has been secreted. These are the graphs that we create. Left one is of the parotid glands. The spike goes up, we give the Lyme stimulus, it falls sharply. This is the normal thing that happens. In the hepatobiliary system, we mainly use to image the liver, like in the cirrhotic liver we see here. Left side is the normal scan, normal liver uptake, whereas on the right side the liver uptake is very less and it has shifted to the splenic uptake more. Now this is the hepatobiliary or the HIDA scan, normally done in biliary atresia patients. This is a normal scan. Very clearly the activity is seen coming out. This is the atresia, biliary atresia, in which the activity is retained even at 24 hours. In cardiology, we do a group of tests. Many agents are there, but over here, we are basically doing viability scans. This aids in the diagnosis of CAD, evaluation and risk stratification, preoperative evaluation, a follow-up tool for patients with known ischemic heart disease, post-CABG and angioplasty assessment. For this all assessment, we have a perfusion test, that is exercise stress test. And for the patients who cannot physically exercise, we have pharmacological stress test. So this is a normal, how it would look like. If we see the first two, it looks like a complete donut. Nothing is missing from the circle. But here is this is the polar map that we create, 20 segment polar map. It divides into 3 territories, LAD, LCX and RCA. That is how we segmentize it. It gives the EF. Now this is the single vessel disease and it is the LCX one. We see on the right side, there's a missing part. That is the right inferolateral. It is the inferolateral territory, that is LCX territory. This is the multi-vessel disease. Inferior wall is deficient in the uptake. Now another is myocardial viability scan, PET scan, that we routinely do here. And it is seen for the viability. Perfusion will tell if the blood is reaching that area of the myocardium. Whereas in cases of occlusion, we need to see if it's a long standing, whether the cells there are viable or not, whether intervention is going to help or not. So for that, we see the metabolic imaging of the myocardium. So this is the imaging. This was a person with a TVD. And EF was barely 30%, but the PET came out so well that intervention is going to help him a lot. This is the graph that we create. Second image tells us about the 3 territories, how the division is done. And also we do the radionuclide ventriculography for the ejection fraction of the patients, especially the patients undergoing chemotherapy, cardiotoxic chemotherapy. And we have a role in the musculoskeletal system. Like I told, MDP, here PET also plays a role with F18. And this is a normal bone scan. This is a bone scan with extensive metastasis, left side. We call it a super scan. It has axial and appendicular, all metastasis is there. This is the osteosarcoma. For this, we usually do a 3-phase bone scan. We do a perfusion phase, we do a blood pool phase, and then we do a later phase, delayed phase. And it is used in monitoring the disease progression. Initial 4 months, it was just one rib, and later on, we see how much skeletal metastasis has progressed. This is in the osteomyelitis. On left side, you see the 3 phases done. Perfusion phase, second is the blood fuel phase, and third is the delayed uptake. Venography, not done now, but still I included the slides. And last but not the least, we have the lymphoscintigraphy for staging the lymphedema in the patients, lymphatic obstruction. We give pedal injections of sulfur colloid, and then we image the patient. This was a normal one. The lower side is the head end, and the upper side is the foot end. We see increased activity in the foot end, and we see inguinal lymph nodes labeled. It reaches the inguinal lymph nodes in the first image itself. So it shows us that very normal scan it is. So, as per Dr. Homi Jahangir Baba, father of the Indian nuclear program, for the continuation of our civilization and its further development, atomic energy is not merely an aid, it is an absolute necessity. So is the nuclear medicine that brings its origin from the Homi Baba National Institute. Thank you, sir.
Thank you very much, ma'am, for showing us beautiful pictures. At least we will not be able to read those because that is a specific expertise. But from seeing the picture, we will come to know that this is what scan.
Yes, sir.
So thank you very much for apprising us. And what you are doing is the first center in this region,
Yes,
I
sir.
think. And it is a great facility
Yes,
for
sir.
all of us. Thank
Yes,
you
sir.
very much.
Presently, it is the only functional center here with 2 scanners, sir.
Yes.
Otherwise, patient has to go to DMC
Yes.
and further to PGI.
Yes.
That's it. Thank you,
So
sir.
great job done.
Thank you. Thank you, everyone.
Thank you, ma'am, for sharing your knowledge with us. And